Good afternoon and welcome. My name is Arshad. I am the Health and Wellbeing Lead for UK MSA. And alongside me, I have Lee Calladine, who is an events coordinator for Diabetes Research Wellness Foundation, so also known as the acronym DRWF. And then also we have Tim Scott from UK MSA, who is an operations officer and will be behind the scenes making sure everything is in working order. I am pleased to say today's webinar marks the first in what we hope will become a regular series of events throughout the calendar year. It represents the beginning of an ongoing commitment to provided targeting, meaningful sessions that focuses on well-being, with key messages delivered through a range of specific workshops. These sessions will be designed to support and engage and inform participants, creating opportunity to explore different aspects of well-being while fostering a culture of continuous learning and support. So today's webinar is designed for people aged 50 plus and focuses on practical NHS-backed guidance. Before we begin, I just want to say that this is meant to be an interactive session. So your experiences are really valuable. So please do take part and share your thoughts where you feel comfortable. There are no right or wrong answers. So if anyone feels comfortable sharing, would really value hearing your experience because your experience could resonate to the next person in the webinar. If you'd like to remain anonymous, that's okay too. But please do type a question in the comment section and we will try our utmost to answer them to the best of our knowledge. I would also like to point out that we do have some pre-prepared questions, but if you don't have any questions, then please do say hello and let us know which shed you are from. It gives me great pleasure to hand over to our guest speaker, Lee from DRWF. Lee will give us a little intro about himself and he will have a few slides that he wants to share with us. Thank you. Lee, all to you.
Good afternoon, and thank you, Arshad and Tim, for inviting me to speak with you today. It's a great honour. I'm glad that you mentioned that today's webinar is for shedders over the age of 50 because I fit into that category quite nicely. So a bit of background about myself to start with. My name's Lee Calladine. I have been the educational event coordinator for DRWF for 20 years this year. That's gone very quickly. It's been an amazing journey. And in my role here, I have grown and evolved our educational event program over the years to support people living with diabetes and their family members and even friends, because we know that people with diabetes, their care involves the people around them as well. In my role, I work nationally with the NHS. It's the diabetes specialist teams that facilitate all of our events. So even though I'm not a clinician, I'm not a healthcare professional, I do work very closely with the diabetes teams, specialist podiatrists, dietitians, clinical psychologists, exercise professors, anyone that's involved in the diabetes arena that helps us support people living with the condition. We have, over the years, had a whole series of events, from one-day events for people living with all types of diabetes, cooking days. We've worked with Ramblers to do exercise weeks to get people out and active to help manage their diabetes. We've done residential weekends. COVID was a big change for us. You probably all know that brought things to a grinding halt. And after COVID, we kind of reinvented the event program, and we did some really big central events in Warwickshire for the whole country. We did those for a couple of years, and now we're going backwards a little bit to what we know best, and that's regional days, some of our residential weekends, and actually a lot of online content, because we know that things have changed after COVID and people are accessing much more online content, which fits with people's modern lifestyles as well. So that's me. DRWF, we've been in the UK for about 28 years. The charity started in the United States, and our trustees who set the charity up there all had children with type 1 diabetes, and they wanted to raise money and raise awareness to fund research into a cure for type 1. The charity is about 30 years old in the United States. They eventually set us up in the UK. We've got sister charities in France, in Sweden, in Finland, and in Norway. We all work very, very differently. We're autonomous, but at the same time, we may cross-fund research, because we know that research is an international effort. It doesn't work. It doesn't work in per country in isolation. So in the UK, DRWF has distinct aims. We have three. One of them, as I've mentioned, is research. So the charity funds research into diabetes. Here we go. We've got some slides to go through. So I've mentioned who are DRWF. As a charity, we are based in the UK. We are registered. We are national, and we fund research into diabetes. That may be looking for a cure for type 1 and type 2. It may be new medications. It might be research into the causes of diabetes, new technology, because we know that managing diabetes is multi-leveled. So it may be that something like the recent hybrid closed loop, where you've got an insulin pump, a continuous glucose sensor, and a mobile phone app that talk to each other, that help people with type 1 manage their diabetes, is not a cure, but as close to an effective cure as you may get in current times. The research could be into looking at genetic patterns in families. That's a big study that's recently been happening to see if there are genetic markers between siblings and family members. On our website, we have a huge section about research. You can have a look on there, and you can see all the research studies that have gone on, clinical, non-clinical. We have a fellowship program, and we have something called pump priming, which is funding for breakthrough young researchers. So that's one of our main aims of the charity. Another one is raising awareness. So for us, that means going out into the community. It means talking to groups, talking to the public, doing stuff on social media, getting news out there, articles in magazines, and any kind of route where we can talk to people, let them know about diabetes, let them know about the signs, the symptoms. Talk about that a little bit more in a moment as we go through the webinar, through the slides. Our other aims are education. So in my role, one of our main aims is providing educational support to people with diabetes so that they can manage the condition, so that they can look after themselves. It's a complex condition. Diabetes, we hear about it on the news. People that haven't got much knowledge about diabetes may think, oh, well, you can't eat sugar or you can't eat cake, but it's actually a very complicated condition to live with and to manage. And so our educational program helps people navigate all of those challenges. Okay, and there you go. At the bottom of the slide there, our strapline, staying well until a cure is found, pretty much encapsulates what we do. We know that a cure might be a week away, or it might be 10 years away. But if we can help people look after themselves until that day, then hopefully we're doing a good job. We know that living with diabetes, if it's not managed well, can lead to serious complications. So that education, that awareness, it's all about preventing and delaying anything like that happening. Okay, so next slide, Tim, please. Okay, so it's a big question. What is diabetes? So we've got some other slides about type 1 diabetes and type 2 diabetes. They're both called diabetes, but they're very different creatures, if you like. This slide, I think, will actually, should we skip over this one, Tim, and go straight to, here we go. It's probably easier if I just differentiate between the two. So type 1 diabetes, this is very different than type 2. It's an autoimmune condition. And what happens is, for some reason, and researchers are still working very, very hard to figure out what the mechanisms are, and they've done a lot of amazing work, especially recently. We know that for some reason, the body's immune system turns on its own insulin-producing cells and attacks them. So every time you eat something, every time you drink something, any type of carbohydrate that goes into the body, it's digested. The sugars or the carbohydrates, that's the complex name for sugars, go into the bloodstream. The pancreas releases insulin, which is a hormone. The insulin attaches itself to the glucose molecules in the bloodstream, and it carries them out of the bloodstream around the body to muscles, the brain, internal organs, and that's where it's used as fuel. The insulin's got another job as well. It acts like a key. The insulin unlocks the cell, transports the glucose molecule into the cell, and then locks it again. So that's quite a complex system going on in the body. If a person's diagnosed with type 1 diabetes, it means that their body's not doing that anymore. And that's because their immune system has attacked those beta cells that produce insulin and release them into the bloodstream. So without the insulin, glucose stays in the bloodstream, blood sugar levels start to rise dangerously high. Without the presence of insulin, or without having access to injectable insulin, the body's going to start looking for another fuel source, and it will start to break down tissues, muscles, sinews in the body, looking for a fuel source, which also has a horrible side effect of creating ketones and something called diabetic ketoacidosis, which can be fatal. So type 1 diabetes is a serious condition, and we'll have a look at some of the symptoms. Can we go to the next slide there, please, Tim? Okay, so we can. I think we can skip that one as well. There's a picture of the pancreas and the beta cell. Okay, so here are some of the symptoms. Now, with type 1 diabetes, because it's usually a rapid onset, because the immune system destruction of the beta cells happens quite quickly, these symptoms can appear, and they're very profound. So I've got type 1 diabetes. I've had type 1 diabetes for 25 years, and I remember very, very well in the beginning when these symptoms presented themselves. I went from feeling very healthy to being in hospital in less than 2 weeks. And the first thing that I remember was thirst. I had an unquenchable thirst, and that is one of the key symptoms. And that's because the glucose levels are so high in your body is trying to tell you to drink fluids, because it needs water and fluids to flush out that glucose. And it does that by flooding the cells. And because you're drinking a lot of water, another symptom is weeing a lot. And we know that especially at night, that is a noticeable thing. During the day, you might be drinking lots of water at work, going off to the loo, but because you're doing that through the evening as well, you'll be getting up all night to pee. The other side effect that is, and symptom that's very noticeable, is weight loss. And again, that can be very profound. I lost a lot of weight within a week and a half, 2 weeks. So much so that my friends and family were quite alarmed at what was going on. And because of this onset was very quick, and as a man, because I know that some of us men are terrible at going to the doctor, I put it off thinking, I've got a cold virus, I've got a flu bug. But I knew something was wrong. I went to the doctor. He did a urine test. He did a blood test and sent me straight up to the hospital, where I was immediately put onto an insulin drip and fluids and potassium, because my level of ketones was incredibly elevated. My blood sugar levels were over 30. And so all these classic symptoms were presenting themselves. There's some other ones there. Eyesight change, absolutely. Your eyeballs start getting flooded with fluid, so the lens changes shape, so you will probably get blurry vision. Genital itching, unfortunately, that does happen because you've got all this sugar in your blood and in your urine, so you start getting itching, and some people get infections. Wounds and bruising, that's something that happens, but once you've got diabetes, it's something that tends to stay with you, and that's a slower healing of bruises and wounds. So you've got some classic symptoms there. If you are noticing any of these, the first thing to do is go straight to your GP. You can go to your emergency walk-in centre. You can go straight to A&E, phone 111, but don't leave them. If you're drinking lots of water, if you've got excessive thirst, if you're losing weight, then get to the GP or the hospital and get yourself checked out. If you can't do any of that, go to your local pharmacy and ask them to do a blood glucose check for you, and they will. Okay, next slide there, please, Tim. Okay, so that's type 1. And again, as we said, it's a very different animal than type 2. Type 2 diabetes is the diabetes that you hear about the most. So this is the one that we hear about on the news, in the media. A bit more complicated again. There are many reasons for it. The one we hear about the most is lifestyle, and that's largely true. So the bulk of people with type 2 diabetes get diagnosed because they are overweight, they're not doing enough exercise, and when you put on weight around your middle, especially for men, because that's where we carry a lot of our weight. That puts pressure on your system. Your insulin can't work as well in your body. So you're kind of making it work uphill almost. And you end up your cells become resistant to your insulin. That's one reason. The other reason is age. So we know that over the age of 40, people start to make, not everyone, but some people start to make less and less effective insulin. So it may be that your insulin production is slowing down, your blood sugar levels start to creep up slowly, and you might need tablets. Or some people manage it with diet, some go on tablets, some have insulin. So different levels at diagnosis. We know that other factors come into play with type 2 diabetes as well. So gestational. So for the ladies out there, gestational diabetes is quite common. And most ladies, when they're pregnant, get type 2 diabetes. It's managed through the pregnancy, but once they've had the baby, that disappears. We know that people from the South Asian and African Caribbean community are about 7 times more likely to get diagnosed with diabetes than Caucasian European people. And that's purely down to genetics. So we've got multiple reasons for type 2 diabetes: age, ethnicity, gender, and also lifestyle. When it comes to, and I've missed one, which I can see in my notes there, hereditary. That's very important. If it runs in the family, then you're at an increased risk of getting type 2 diabetes. So again, regular screening with type 2 is important. You can ask your GP, you can go to your pharmacist, you can even get yourself a home kit, a little blood glucose meter if you want to, and you can buy those from pharmacies if you want to test your own blood sugar if you're worried. Okay, could we have the next slide there, please, Tim? Here we go. Now, I've put this slide in again about symptoms because they are similar, but with type 2 diabetes, because the onset can be slow, you may not notice these symptoms straight away. You may only get something like the thirst or weeing a lot once your blood sugar levels are at a really elevated level. And that's normally because they're coming on slowly over time. And so you get used to them, your body adjusts to them, and you don't notice something's wrong until they're, quite pronounced. We know that most times people get diagnosed with type 2 when they go to the doctor for something else. So you might go in for a blood test for something completely different, and then the doctor phones you and says, I think you better come and see me because your blood glucose levels are a bit high and we need to have a look at them and see what's going on. So with type 2, as I mentioned earlier on, with all of our awareness raising, our community work, our education, we're trying to make people aware of these symptoms, and we want people to be aware of them and getting checked out regularly. There's nothing wrong with going to your GP once a year and asking for a urine test or a blood test, or like I said, even going to the pharmacy. If someone has got very pronounced type 2 diabetes, then absolutely you'll be finding that these symptoms very much start to play out. So yeah, again, with anything like this, straight to the GP, to the pharmacist, to the walk-in centre, or even to A&E if you're really worried. Okay, next slide there, please, Tim. So other types of diabetes. So we've mentioned gestational diabetes. That is quite common among ladies. There are 2 other types of diabetes, Modi and Lada. They're very rare. And what I would say, going back a step, type 2 diabetes makes up about 93% of all people worldwide with diabetes. So when we talk about diabetes, type 2 is by far the most prevalent. Type 1 diabetes, again, makes up about between 5 and 7%. The numbers of type 2 diabetes is rising constantly. This is something that we're well aware of, especially in the UK. And that's why there's been such a campaign and a push to make people aware of type 2 and getting checked out so that they can it can be prevented, or it can be delayed, or it can be treated. Type 1 diabetes is a very small percentage. That's because the numbers of type 1 diabetes tend not to change. We've seen that pattern as quite consistent over the years, apart from COVID, when for some reason there was an elevated spike in type 1 diagnosis. So obviously something genetic was going on there with the immune system in people. Type 2 diabetes, alarmingly, is also something we're starting to see in children. If you go back 6-8 years ago, this was pretty much something that was never talked about, never seen. But again, because of lifestyles, perhaps children aren't going out and playing on their bikes as much as they used to. They're using computer screens more. Diet. We're starting to see type 2 diabetes present itself in children as well, which is quite alarming. So again, a lot of awareness raising around that. These two other diabetes, MODY and LADA, very much linked to genetics, a bit like type 1. Okay, so next slide there, please, Tim. So complications of diabetes. I've mentioned that awareness raising and education is incredibly important. And one of the things that we do at the charity is try to drum into people the management of diabetes, because we know that good management can prevent, delay, or prevent these complications. Diabetes, historically and up to now, is the leading cause in heart attacks, liver failure, kidney disease. It was in blindness, amputations. It's a vascular condition, so it affects the large vessels in the body, the smaller, more intricate vessels. So blood flow to things like toes and fingers can be affected. There are changes in this with advances in insulins, in tablets, in technology, where people are able to manage their diabetes much more effectively. When I think back to when I was first diagnosed 25 years ago, I had a basic blood glucose meter. It was a big chunky thing. Used to put a test strip in it, take a big blob of blood, and that would tell me what my blood sugar was literally at that moment. It didn't tell me anything else. And then slowly over the years, we've had newer technology. We've had smarter meters with built-in diaries, then meters that you could put in your insulin doses and your carbohydrates, perhaps. Meters that would plug into a system at the hospital so they could download your data. Now we're using glucose sensors. So I wear something called a CGM, a continuous glucose monitor. That's taking blood sugar readings all the time and sending the results to my phone. In fact, they don't take blood readings. They take readings of interstitial fluid. Then they calculate the blood glucose level from that, send it to an app on your phone so you can see what it is. They give you directional readings so you can see if your blood sugar is going up, going down, going up fast, going down fast, or if it's level. You can set alarms. So if my blood sugar levels start to go, I've got a range that I've set, a very clear range that I like to stay in. If I start to go above or below that, I'll get an alarm on my watch, on my phone, to let me know. And then I can do something to counter it, whether that's taking extra insulin or having some jelly babies to bring my blood sugar back up. I can do something about it, but I've got a constant stream of data showing me what's happening. And that means I can manage my diabetes much more effectively. If it's doing something that I'm not sure about or is unusual, I can email my doctor at the hospital and he can log in remotely and he can look at my data and he can say, Lee, I can see that you had a full English breakfast there and a couple of extra slices of toast, and I think that's why your blood sugar is doing that, or I might be unwell and that's affecting it. So the technology now is incredible. Insulin pumps for people with type 1 diabetes are incredible, and they talk to the glucose sensors. They also talk to the app, and they also talk to the hospital. So you create this complete loop of technology to help the person manage their diabetes. And we've already seen through data in recent years that the use of this tech is helping to massively reduce some of these complications in people. It's reducing hospital admissions, it's reducing admissions for DKA, which is the diabetic ketoacidosis we mentioned. So wonderful. When it comes to, that's mainly type 1 diabetes, people using that kind of tech. People with type 2 diabetes, they do use technology as well. And there's a lot of new sensors now that are coming out specifically for people with type 2 diabetes. Type 2 diabetes, depending on when you're diagnosed, you may be diet controlled. They may put you on tablets, and there are lots of different tablets that do different types of jobs. Some tablets help your body make your insulin work a bit more effectively. They help your body to stop producing stored glucose. Some tablets act like insulin and they lower the glucose levels. Some work in combination, and then some people with type 2 do end up on insulin as well. Sometimes people get confused and they think because they're on insulin that they suddenly become type 1, but that's not the case. If you're type 2, you're always type 2, whether you're on insulin or tablets. If you're type 1, you're always type 1. Type 1 diabetes is managed from insulin from the start, because the person goes from having insulin production to having no insulin production. So they need to go on insulin injections for the rest of their life at the moment. The research may change that in the future. That's something we really, really hope for. But they have to go on insulin injections, and I probably do 8 injections a day. My insulin's very clever. I have background insulin so that I've got a constant presence of insulin in my system all the time, and that's very slow release insulin, and that's important because that stops me having the risk of ketones in my body. And then my fast acting insulin, I take that with my meals, with my snacks, and it's called dose adjusting and carbohydrate counting. And with that, I work out how much carbohydrates in my food. So if it was a slice of toast, that might be 20 grams of carbohydrates. And I know that I need to take 2 units of insulin, but that would be different if I was having porridge or if I was having an apple or a pizza. So it changes all the time. And after a a few years of living with it, you have an inbuilt food calendar and diary in your head, and you can work out all of this, these facts and figures just by looking at what's on your plate and how much insulin to take. So it's a complicated condition to live with and to manage. And as a charity, and there are other charities as well that help people with diabetes, and of course specialist diabetes teams that will work closely with the person to help them manage their diabetes. Again, we know that's not a one size fits all. Each person is different. So as a person with type 1 diabetes, what works for me may not work for another person with type 1 diabetes, and the same goes for type 2. So we're all different shapes, different sizes, different ethnicities, different ages, and so our diabetes management's going to be tailored pretty much to the person. And we're seeing that even more now with different technology, cleverer insulins, different tablets, and even things like needles. So when I first started, needles were quite long. They were very painful. I used to bleed all the time. And now I've got these very lovely little 4mm needles that I hardly feel, that I don't get any problems with. And that's all come from ongoing research and involving people with diabetes in that research as well, which is very important. So, next slide, I think, please, Tim. Okay, so this one I put in just to give us a little bit of an idea about the numbers of diabetes in the UK. So 5.8 million people in the UK with diabetes. I think you'll agree that's quite alarming. We know that number is rising year on year. We know when it comes to type 2 diabetes that there's about 1.3 million people walking around with undiagnosed type 2 diabetes. Again, this is another reason for the awareness raising, for getting information out there, education out there, trying to let people know about it. And I always think, if diabetes isn't on your radar, why would you know about it? Why would you look at this stuff? So it comes down to people like us, the NHS, the media, to keep pushing this information out there to get people thinking about it. I've mentioned children being diagnosed with type 2. You can see that stat there, 72% increase over the last 4-year period. I mean, that's shocking. And the other shocking stat, which you can see there, and I put it in red and bold at the bottom, is the annual spend that the NHS has on managing diabetes. £10 billion. That number is increasing, and people within the NHS have raised flags to say that if we don't get a grip nationally on diabetes, primarily type 2, that number is going to keep going up, and it could bankrupt the NHS at some point. Again, the NHS has got some amazing programs in place. There's something called the Type 2 Prevention Program, which your doctor or your GP can put you on, refer you to if they think you're at risk of type 2 diabetes. And if you do get diagnosed with type 2 diabetes, there's something called the NHS Path to Remission Program. And that's where they put you on a 12-month program to start with, and you work with diabetes nurses, diet, their weight, exercise, to put their diabetes into remission. And we say remission, we don't say that it's cured or it's gone, because we know that when people lose weight, especially as I said earlier with us guys around the middle, you can take that strain off your body. The type 2 diabetes can go into remission because your insulin starts working better. But if you start going back on the cakes and the pies and you start putting on weight, or you're not doing your exercise, unfortunately that type 2 is still there and it will just come back again. But these NHS programs are amazing. They're free and they're available to anyone, and your GP can refer you to those if you need to go on them. So next slide there, Tim, please. Okay, so I think in a nutshell, I could talk a lot more about the different types of diabetes, and we could go a bit more in depth. But I know today we just wanted to touch on some of the different types of diabetes, how they're managed, and some of the signs and symptoms to look out for. We've got a lot of information as a charity. You can approach us afterwards and we'd be happy to send any information out to you. I know Arshad will very kindly share some of these links with you. We've got a whole series of information leaflets that are all free, and these are everything from exercise, eye health, foot health, liver and kidney health, diet and how to eat healthily, sick day rules, and we've got some other lovely resources like this booklet that tell you all about the charity, and we can send those out for free. On our website we have podcasts, we have webinars. This year we're doing a web series. One of those episodes is going to be about men's health, and Arshad is very kindly joining us for that, so look out for those on the website soon. But if you've got any questions at all, you can email us, you can give us a ring. We're a small team. We're based near Portsmouth, down on the south coast, and we've got one office, and we run the charity for the whole UK from our office here, and we also support our colleagues in Europe. So do give us a call or an email, and we'll be pleased to help you out. Next slide there, Tim. Are we at the end?
We're at the end. Thanks
Wonderful.
So much, Lee. That was a really, really interesting and comprehensive overview, delivered really quickly. So if it's all right with you, I wouldn't mind asking some questions, some that have come from our audience who are watching, and some that we think are quite interesting that people who might watch this video in future would really want to know about. So the first question is from our viewers today, a couple of whom have talked about being pre-diabetic. I just wondered if you could give us some advice about what to do if your doctor tells you you're pre-diabetic, and how to sort of manage that over time.
Yeah, sure. So pre-diabetes. So what happens when you go for a blood test? They look, what they do, they call it a HbA1c, and it's glycated hemoglobin. So your hemoglobin has a 3-month lifespan. Where it's traveling around your body, it gets things stuck to it, molecules of debris from the bloodstream. One of those is glucose, and they can tell by looking at that blood sample and the hemoglobin's journey over those 3 months, how much glucose you've got in your bloodstream and what your glucose control is. And from that, they can allocate a score, and they can tell where you're sitting and how, whether you're pre-diabetic, if you've got diabetes, or if you're even further along in the journey. Getting a diagnosis of pre-diabetes, I say, is good. I would, in the scheme of things, you'd rather find out before, wouldn't you? So if you score as pre-diabetic, that's when perhaps something like the prevention program can come into play. If you're on the border, they may put you on the Path to Remission program, and what they'll do there is they'll help you look at your diet, your exercise, lifestyle, any other factors that may be coming into play to put you at risk of diabetes, or even have type 2 diabetes. Pre-diabetes is type 2. With type 1, you won't have pre-diabetes. You'll have diabetes or not. So pre-diabetes, definitely type 2. In a lot of cases, with pre-diabetes, it's actually down to diet control, and then they'll keep an eye on it. And usually with a HbA1c test, you'll go in to see the nurse every 6 months or every 12 months, and they'll keep a careful eye on it. And if those glucose levels start to change or you're starting to go up, they'll talk to you about diet again, might make some more tweaks, or even put you on a tablet like metformin, which is widely prescribed for type 2 in the beginning.
Thank you. Obviously, a diagnosis of pre-diabetes can be concerning. People will want to perhaps react quite quickly. I just wondered what your views were on either fasting as a way to managing your health, or radically increasing your exercise. Any concerns about those two approaches?
I would say when it comes to, if you're worried about diabetes, these are always questions to have with your healthcare professional. That's what we say to everybody, especially before you start making radical changes to your health or diet or exercise. I think it's always, it's always a good thing to get some advice first, especially if you've already got diabetes. I would say talk to your healthcare professional, absolutely.
Great, thank you. You've shared a little bit about your own experiences living with a very challenging condition. Do you ever find yourself feeling overwhelmed by living with type 1?
Yeah, that's a really good question. And I know I kind of skimmed through those topics very quickly, and things like complications. But yes, I do. For the most, I've been managing it for so many years. I kind of just get on with it. But we know that there's something called diabetes burden and diabetes distress. And we know that people can feel that burden of living with a long-term health condition, especially managing it. And actually, funnily enough, in recent times, with all the new technology, we're even seeing something called things like alarm fatigue. When your phone keeps beeping at you because your blood sugars are doing something that they shouldn't, or your insulin pump is beeping at you. So that's very much a real thing. And clinical psychologists within the NHS and the diabetes teams do speak to people about the burden of managing something like diabetes all the time.
Well, thank you for sharing that. So what impact has it had on your friends and family? How have they had to adjust to support you?
I think in the beginning, obviously, that they have to learn. Again, I guess it depends on whether it's type 1, type 2, or a different type of diabetes. But I think it's important for them to learn and understand about the diabetes as well. If their family member has a hypo where their blood sugar drops too low, they might need to step in and do something to help. If your blood sugar is high, that can also be very problematical, and family members need to be aware of some of the signs and symptoms. So we're talking about a completely different set of signs and symptoms now when it comes to high and low blood sugars. Hypoglycemia, which is the low blood sugar, that normally happens like glycoside. Excessive exercise, as you mentioned, Tim, that can cause a low blood sugar episode. I have to manage exercise and activity very carefully with my insulin, especially in hot weather. and your metabolism speeds up. So your cellular uptake of everything changes and is much faster. So I think with hypos, they can come on slow and gradual, and you'll get some warning symptoms. You might start to feel a little bit dizzy, a bit trembly and shaky. You're a bit drunk in your mind. You're not. Your brain and mouth disconnect starts to happen, and your brain's not working as it should, because again, it functions on a very delicate balance of glucose. So sometimes it's family members and workmates and friends that notice something's not quite right even before you do. Luckily, I get good warning symptoms, but if a hypo comes on quickly, and they do, it can catch you unawares, and that's where family members and friends, if they know to grab the Coke or sit you down and get you something to eat with some carbohydrates in, and keep an eye on you. High blood sugars are a bit different. They tend to make me feel very tired, very sleepy, very irritable. You don't want high blood sugar levels for too long, because that's when your blood is full of glucose, and that's when you start to get that vascular damage that we talked about when it comes to the heart, kidneys, liver, and extremities. We talk about neuropathy, and that's damage to the small blood vessels in the feet and the fingers. That's why you see a lot of amputations, or historically amputations, in people with diabetes. It's because high blood sugar levels over a period of time affect the small vessels and the nerves, and because the blood, because your blood's full of sugar and it's thicker, it can't get into the blood vessels. That's what's happening, and that happens with the eyes, and over time it can affect the macrovascular, which is the bigger vessels as well. So that's why we don't want the high blood sugars, and it's all about managing the diabetes and keeping them in that range that we want them in.
Thank you. Did
I go off piste then? I think
that was really comprehensively. Thank you. I've got a couple of questions about symptoms, if that's okay. The first, if you were out in public without any friends or family and you became unwell, how might a stranger identify that you were being affected by diabetes?
Okay, so
do you carry anything, or is it obvious?
Yeah, Joe, I always say to people with diabetes, all types of diabetes, particularly if you're on insulin or glucose lowering tablets, if you've got type 2, or if you're on insulin with type 2, do not go anywhere without some glucose. Your blood sugars can really catch you unaware, especially if you're doing physical activity, or if it's hot weather, or if you've, skipped breakfast. So I've got a, where is it? I've got my necklace that I wear. I put it in here so I can get it out easily. So this has got all my details on. Next of kin, it says what insulins I'm on. It's got my dad's phone number, and that I've got type 1 diabetes. I wear a wristband that says I'm insulin dependent, and I always carry Coca-Cola. I've got Jelly Baby. I've got them everywhere, in the car, on my desk at work, on my bedside cabinet, in my work bag. So when I go out, it's almost like autopilot. You know what you have to take with you, because you don't want to get caught short. And some people can carry a wallet card. You can, just as long as you've got something on you that says you've got diabetes. But I would say, don't go out without any glucose, because that's the lifesaver. And something that tells people, I've been unconscious and in A&E before, and the A&E doctors knew exactly what insulin to give me, because that's the other thing. There's lots of different insulins, and people are on different types depending on their diabetes and how they manage it.
Thanks, Lee. I've got one more question about symptoms, and this is from one of our viewers today. They've identified that a member of one of their sheds was diagnosed with diabetic symptoms that turned out to be something else. You've outlined some of these symptoms. Are there any red herrings, any common misconceptions? People assume it's diabetes and it's not.
Gosh, yeah, that's a good question. I suppose if it is the classic, I mean, amazing that they identified some of these symptoms. I mean, that's great to know that people out there are aware of them. Do you know what? If they're showing the classic symptoms, the thirst, the weight loss, the peeing a lot, any of the others, there's no harm getting them to the GP or the chemist to get checked. If it turns out to be something else, then so be it. But I'm sure there will be other medical conditions that have similar symptoms, but yeah, getting them checked out. And any concerns, any worries, just go. Pharmacists are brilliant. Most pharmacists now have a expert pharmacist in branch, so that you can go and have a chat with them if you're concerned. They can do a blood test. They can do a urine test. I know it's not easy to get a GP appointment all the time these days. So, but like I said earlier, if you are worried and you can't get a GP appointment, pharmacy, or even go to the walk-in, and if you're really concerned, go to A&E.
Thank you. And my last question is just about the technology. You've talked about some of the things that perhaps you wear or that connect to your phone. What's the eligibility criteria for that?
Okay, so a lot of work's been done over recent years. There's a chap called Professor Partha Carr. He's based at Queen Alexandra Hospital in Portsmouth here, our hospital. He was the national clinical lead for diabetes, and he spent a few years spearheading up getting technology made available for all people with type 1 diabetes to start with, because the continuous glucose sensors and pumps were very much tailored to people with type 1. That campaigning is carried on. So now that the tech companies are bringing out newer sensors for people with type 2, they're going to be much more widely available. Eligibility, all people with type 1 diabetes are eligible for continuous glucose sensors, or CGMs. There's a couple of leading companies, Dexcom and Abbott. They're the two main sensors, and you can choose, whichever your preference is. Insulin pumps also available for people with type 1. Not all people decide to have one, because it means, again, having something stuck on your body 24/7, and some people don't want that. There are pumps with tubing. There are newer pumps now that have got all the tubing inbuilt, so you've just got a patch pump, and they're much more discreet. For people with type 2, eligibility, again, it's a bit different depending if you're pre-diabetic, if you're diet controlled, if you're on a tablet like metformin, or if you're on glucose lowering tablets or insulin. So again, that's a conversation with your healthcare team, with your GP. That might change between trusts as well, because each NHS trust might have a different way of working. But we do know that there's tech coming out that's specifically aimed at the type 2 audience. So that's going to change. It's changing now, and it's just going to carry on changing.
Great. Thanks very much, Lee. That was really, really helpful. Arshad, do you want to just recap on your role and how to get in touch?
Yes, of course I can. So, big thank you to all of you for taking your time to join us today and for your participation throughout the session. I'd also like to extend a sincere thank you to the Diabetes Research and Wellness Foundation for their continued work and support in helping people live well with diabetes. Also, a big thank you to Lee for his very informative presentation slide and his subject knowledge. So thank you, Lee, again for your time.
My pleasure.
I would also like to thank the Health and Wellbeing Group for their continued support. And we hope today has given you useful, practical information and a bit more confidence in managing your health. I just want to say, remember, small, consistent steps can really make a big difference. So, and make a big difference to your health. Feedback from participants will really help us shape future events. So if you can improve the topics or the format and the content, keep them useful and relevant, please do let us know. This will help us to build sessions that will better support us and engage everyone while promoting the well-being. If you do have any questions from the sessions, then please do reach out to myself or Lee. My details should be available on screen now. So if you want to get hold of us or get hold of me, just send me an email or contact me directly through my telephone number. That will be very useful and very helpful. And I will try and direct you and signpost you into the right direction. And any complicated questions that you may have, I will surely be directing them to Lee and his professionals, and they will also get back to us with regards to the answers to your questions. Tim, is there a short video that we can play?
There is, yes. So we'll end the session with a short video, which I'll pop up on screen now. Thank you, Lee.
Living with diabetes can be extremely lonely. When you're at home, you're on your own. I think it's so important for people to be able to come together and have these very open, genuine conversations that you just don't or can't have with other people.
Today is our biggest event of the year. United Through Diabetes is about bringing together communities from all over the country, and it's focusing on providing educational support, resources for people with type 1 diabetes, type 2 diabetes, and you can see this just look on their faces of relief.
As soon as you arrive, you just get such a good feel, you know, it's a nice vibe.
Having different people's perspectives on having diabetes and the experiences that they've had is really, really useful.
There's so much expertise, there is so much enthusiasm.
It's very cool that I can chat to other people with type 1 diabetes to see how other people are dealing with it.
I came today to support one of my friends who was diagnosed last year.
I'm here because in my primary school it was just me who had type 1. It can bring people together.
My wife, she deals with type 2 diabetes, and I wanted to get more information about it to be more successful in supporting my wife in this situation.
Seeing that they're having a great day and then going home armed with skills, information, resources that we know are going to help them. That's where I feel proud.
It's phenomenally useful for researchers.
That one-to-one conversations with people with diabetes, with lived experiences, it's really brilliant.
When you can bring people like me and researchers to these events, not only does it help people understand there is a huge amount of research going on in diabetes currently, but also there is hope.
If people were thinking about coming to an event like this in the future, they should definitely do it. It's a wealth of information.
I've had type 1 diabetes for 25 years, so I know what their journey's like, and I know how scary and isolating it can be but it's at the end of the day when they shake your hand and they're saying, I've learned so much.
I love this event. It's so friendly. It's a real mix of everybody in the community coming together to do something really important. Yeah, I love it.
Thank you, Lee, for your time and your contribution today. It's been really invaluable. The recording that we've made will be broadcast on our website in due course. We'll publicize this so it can be seen by the biggest audience possible, because it's been so enlightening. Thank you ever so much.
Excellent. It's great to see that video again. I've not seen it for a while.
Looks very good.
Great. Thank you again. And we wish you all the very best in your health journey. Thank you and bye-bye.